Hello, buenas tardes desde Ecuador. This is our last case of this year. Hello, everybody. Thank you for joining us, and I want to say thank you for all the year, all the support, for all our sponsors, uh, for continue helping us to this education through our live channel, endoscopy live channel, but also um, thank you for helping us, for helping our patients, and for helping for all the physicians around the world to have access to the continual medical education. So today we have our last case that I want to show you to make a live transmission. I believe this is the future. This is something that we are talking about a lot, and where was very discussed before that if we can perform an US and ERCP treatment in the same patient. So we have 60 years old female with history of jaundice and acute cholecystitis, but this patient is not in a good clinical condition to go to surgery in this moment. So now, what can we do? So we will perform a ERCP now today. So because we need to drain the biliary tract, and also at the same time we need to improve the cholangitis, and then I believe I am inside, huh? Yes, I'm inside the biliary tract. You can see, so it's very easier to go and go inside and doing an ERCP. This patient had a small stone down. You can see on ERCP image, really small, and that's why this patient did the ERCP with the sphincterotomy. I will perform my sphincterotomy now, and then we will treat the cholecystitis, the acute cholecystitis by US. Uh, very well. I think I'm fine. Okay, perfect. So you can see a small fragment of stones going out. So these patients have a lithogenic bilis, you can see. So I will pass just the balloon just to clean up, and then I will perform a US to treat the cholecystitis. So cannulation is sometimes is difficult, but in most of the time, we can do an ERCP, quickly and faster, and this is because of the position that you will use before to perform an ERCP, and also a good technique is really important. So now I will pass the balloon. I will clean up. Okay, inflate balloon. So you can see there is a stone inside the gallbladder. Desinfla un poquito, no tan. So now I will. Oh, okay. So now I clean up. Desinfla. I believe it's out everything. The sludge going out. You can see there in the image. The sludge is a lot of sludge inside. Okay. So now I will do a second cleanup. Infla. And I believe with this will be it's okay. So now I finish to clean up. She will be fine with antibiotic. I perform antibiotic before the procedure also So the papilla is now fine. You can see here. And now I will perform a treatment of the gallbladder because of the cholecystitis. So I need to remove the air. I will use my EUS. In the same session, we can do the both treatments, right? So this will help in some patients that have contraindication to surgery, for example, as this patient, and this can be performing, you know, both treatments. One, the cholangitis. Second, to remove slush and stones from the biliary tract. And third, we can treat the cholecystitis, the acute cholecystitis, by US. So now I will pass the US. Necesito la imagen de endoscopía, por favor. So this is the pancreas. So with a lot of fortune, this patient didn't perform at least a pancreatitis. The pancreas seems very well. So now I am using a US linear US from Pentax Medical. No me falta el pedal, por favor. I need to go I am trying to find out the gallbladder. This is the liver of this patient. So this patient have elevated. This is the gallbladder. You can see here. So the GGT and the fall was elevated, and this patient had a stone inside. You know. So now I need. You see, it's very thickness of the wall. I need to measure a little bit. Well, I will try to figure out here. So we see the wall of the gallbladder irregular and thick. You see, 4 millimeters, 4.4 millimeters. So now we need to do a treatment, and I try to see the best approach. It means if I need to go by, you know, transbulbar or through the antrum. So I want to try to see the best position to do the drainage. Here, you can see here. So, because of the inflammation, the wall, you know, the gallbladder is not well distended. So what I will do now is to put some water inside, some contrast also, in this position to make bigger, and go inside with an axios, with lamps. So dame la aguja primero. Vamos a inyectar. So I prefer to do in this way because, you know, it's not very dilated the gallbladder, and I need a space. So I will create the space in the same way that we can create the space as a third space. In this case, we can do it to be sure that we will not miss anything in this patient and avoid complication and avoid an adverse event. So what we'll do nowadays is to drain the gallbladder. Once we drain the gallbladder, we remove the axios 1 month after. So you can see here there is a stone, The stone is there. Very clear, huh? The cholecystitis is very clear. So I am using a Boston Scientific standard needle. This is a FNA needle, 19 gauge needle. Thank you, Boston Scientific, for all the help that we received from for education proposals during the year. One of our bigger sponsor of our center. So I want to see if there is any vessel. So that's why I use Doppler. And now I'm trying to go inside. I need a better position to be stable. I think I am inside, but I'm not so sure. I need to be sure. I cannot see my needle, you see? Sometimes it's not so easy, huh? Sometimes the drainage of the gallbladder is not so easy, so that's why it is very important to be sure that you are inside. I'm not inside, you see? I'm just outside. I believe I am inside now. But I need to be sure. No. I think I made a good decision because of the difficult situation, difficult position, and the move of the gallbladder. Now maybe I am inside. I need to see very well first. No. When it happens, one of the tips that I can do is to change the position of the patient, right? To see, vamos a ponerle el cúbito lateral. I will put in lateral position because she's in supine position because I need to be more stable. Even with the needle, I'm not going inside the gallbladder. No. So now we will change the position of the patient in lateral position. Because I believe will be much better to have in lateral position the patient. You see, look, you can see very well the common bile duct that is inflamed because of the cholangitis here. just here, by US. So this is why US is much interesting and very important to evaluate before to perform an US to perform an ERCP, right? We will have more details of the common bile duct. For example, you can see here very the thickness of the wall. You see here very well the thickness of the wall of the even of the main bile duct. So so now I am trying to looking for my gallbladder to perform a drainage. So now I believe I am better. I need to see my needle inside, right? That is very important. Now I believe I am inside. Mm-mm. No, necesito que me lo pongas en aspiración de nuevo. So, ah, no. I think this is a chronic cholecystitis. This is not an acute episode. Probably if we see the medical history of this patient, let me see here. Let me see if through the antron if I can do something better. Podemos poner buscapina, por favor. Alguien me puede tener aquí el endoscopio. So I need to stabilize my scope. I think I am inside now. Ten aquí. Cannot see very well. Incredible. Purgamos la aguja. I will make a cleanup of the needle. It's okay. Listo, toma. Ten aquí. Aspiramos. No. It's incredible. I cannot go inside. Tengo aquí. Esto está en aspiración. Puedes confirmarlo. Ten aquí. Ten ahí. You see the needle? The needle is there. Maybe. No. Now we are inside. So now I am inside. You see, it's not easy, huh? Sometimes it's difficult. I will flush with saline. I am inside, you see. You can see by US very well. Now we pass contrast. And I will make a distension, because what happened is that I will make a reposition. I will make a dilation of the gallbladder. Contraste. And then I will do my drainage. So I'm very close of okay, now quiero la salina y quiero y la guía. Now we see very well. So I flush with saline solution. I will do guided by the guide wire, because it's difficult. This gallbladder is a little bit difficult. Going like without the guide wire, we can have some risk. Now I am the gallbladder, you see, very well. Okay, now I remove. Momento. So my assistant can remove a little bit. I want to see where's my guide wire. I will use a 10 by 10 lamps, a hot axis, for doing the drainage. This will solve the problem of the patient, and probably we just keep an eye in the following, you know, making a follow-up just by clinical parameters, as was described by my good friend from Valladolid, Dr. Perez Miranda. He have the biggest experience on gallbladder drainage with this kind of patients. Hello? See, it's not so easy. It's not stable. Even if I am using a guide wire, it's not stable. Really unstable. Let's see if I can go inside. See? I'm trying to retake my position to don't be too far. Tenme aquí la... Ahí. Aquí. Conéctate. Ahí estoy perfecto. So now I am inside. I will push a little bit. I will start to open a little bit. Okay, now I am fine, you see? But US is very important. I was a little bit guiding. Now, I am inside the gallbladder. Now, I will, wait, ten aquí. Now, I am sure that I am inside. And now I will deliver my axios, you see here. So very well, a little bit difficult, but I think was a great position. So sometimes I will, tenemos un pigtail de pequeño. ¿Tenemos? ¿Por cuánto? ¿Por 4, por 5? So I will put just a pigtail because of this is I put it in the antrum, and sometimes it move the position, so I want to keep my track very well. So I will put in this case I will put a plastic stand, double pigtail, 7 French by 4 centimeters. Okay. Necesito uno corto. ¿Tenemos corto o no? Sí. 7 French by 5 centimeter. Just to keep the track, because sometimes I had some issues when I do from the antrum, some difficult positions, and the stent can go inside, you know. So now I am making the drainage. You can see it's very well. So I think in the next years we will start to see more and more the management of the biliary tract by these techniques, and not just considering some cases. We'll be using more for almost all cases because it's quick. It's quick. It's it's safety and feasible with good results until now in the literature. So I want to say Happy New Year to all of you. Thank you for stay with us. Thank you to our biggest sponsors, Fujifilm and Perfect Edge, Boston Scientific with um, with Equasurgical, the distributor in Ecuador, Microtech and the distributor Gastritech in Ecuador, and Pentax Medical for supporting us. Has been a very difficult year, but I believe we are ending this year with a lot of satisfaction, a lot of learning a lot about life. So now I am passing, you see, the stone is out. I am passing the pigtail now. Ten, 10, 10. Okay, liberamos. Okay, so is delivered. Now I am sure that everything will be fine. You see in the antrum, the position is a little bit difficult, and now it's well drained. So in those kind of cases, is sometimes if you need it for stabilize, you need to use, you know, drainage through the guide wire. So thank you so much, and a happy new year. See you next year with more cases, and I hope that you make a like and